This presentation is on the topic of communication disorders in sign languages, namely specific language impairment and stuttering as it manifests in childhood. First, we need to make a distinction between language delay and language disorder. A child's language may be considered delayed when the rate of acquisition is behind for the child's chronological age, that is, their age from birth. In the context of deaf children that primarily sign, this actually corresponds with the age of exposure to that sign language. So for a child exposed to sign language beginning at 6 months, who is now 2, we want to compare their language skills to that of a 1.5-year-old with no delay. On the other hand is disorder, where the child may have atypical development. So we might see stagnation at a certain stage. The child might make language errors that typically developing children don't make. They might express language unusually. And it's under this category of disorder where we find specific language impairment and stuttering. It's important to make the distinction between what is an apparent delay and disorder because late exposure to language is almost always a factor in characterizing deaf children's atypical language skills.
In order to define specific language impairment in children, we need to better understand the requirements for a language learning impairment to be given a diagnosis of SLI. These include normal nonverbal IQ, neurological function, motor development, social interaction, no impairments in facial oral structure and function, as well as normal hearing. Note that the requirement for normal hearing necessarily excludes profoundly deaf children and those who are hard of hearing. Various professionals were interviewed to describe their observations of specific language impairment from their work with children who are deaf or hard of hearing. The commonalities included lack of facial cues, which pertain to weak or absent eye contact or blank staring. This does not bode well with the grammar of sign language, which relies heavily on eyebrow expression and mouth articulations. Another error was trouble setting up characters in space, as well as omitting referential information, such as time, place, or person. There was also switching of hand dominance, as well as errors in phonological parameters. These errors are quite common, especially with movement. An SLP describes a 5-year-old who is attempting to sign enough, but instead the dominant hand moved in the opposite direction, toward the body rather than in an outward motion. This produced something closer to the sign for full. Here is an example of another phonological error, this time with regards to palm orientation. An SLP describes a child who is trying to sign want, but had their palms facing down as in the image on the right. We can see the correct ASL production of want on the left, with the palms facing up.
Currently, there are no standardized diagnostics for SLI in sign languages. Diagnostics being developed must be quantifiable, such that there is a clear denotation of how many symptoms have to be present to suggest atypicality, age appropriate, with primary reliance on age of language exposure rather than chronological age, and where possible, language specific, because milestones of acquisition across language families vary. And now on to stuttering.
Before talking about the characteristic of stuttering and its prevalence in sign language, let's first touch base on what is stuttering. According to Arenas et al. 2017, stuttering is a communication disorder characterized by involuntary disruptions in the flow of speech. Some of the stuttering deficiencies in spoken language includes repetition of sounds and syllables, audible and inaudible sound prolongation, and repetitions of monosyllabical words. Although stuttering is primarily considered as a speech disorder and is largely associated with spoken language, but few studies have reported the presence of stuttering in sign language.
Before we get into the prevalence of stuttering in sign languages, let's quickly look at the underlying mechanisms. Why do people stutter? So there are a lot of theories. One is that stuttering may be genetically linked. Charles Darwin stuttered, and so did his grandfather. Newer studies looking at twins and siblings have revealed evidence for possible stuttering genes. A second take on it comes in the form of neurochemicals, chemicals in the brain. Researchers have found links between elevated levels of dopamine in certain brain regions and stuttering behaviors. Furthermore, medication that reduces the amount of dopamine in the brain have been shown to reduce stuttering. While effective, the side effects associated with these anti-dopaminergic medications prevent them from becoming a go-to solution. Next, we come to the idea that brain damage or development disorders to certain brain regions may cause stuttering. While it is true that damage to different areas are linked to acquisition of stuttering behaviors, there isn't enough solid evidence for us to pin down brain damage and stuttering to one area. So that covers some ideas behind stuttering. Now we look at the concrete evidence. Using different brain imaging techniques, studies have shown a couple of things. Firstly, in stutterers, there is little to no connection between language planning and speech execution areas. In some cases, these pathways are even reversed. Secondly, there is a decreased amount of white matter in the left hemisphere in an area of the brain adjacent to the primary motor cortex for the tongue, larynx, and pharynx representations, as well as another part that links word perception to word production areas. This is important because the lack of white matter means that there is poor connectivity between these language processing areas and the left hemisphere. Lastly, during stuttered speech production, the left hemisphere is activated, but during fluent speech production, language areas in the right hemisphere are activated. It is then suggested that activation in the right hemisphere is a compensatory process. We see similar patterns of right hemisphere activation in aphasia and stroke victims.
Cousins et al. 2009 conducted a study where questionnaires were sent to 38 Flemish Sign Language interpreters and 28 employees of special needs school for the deaf and partially deaf in regards to observed deficiencies in manual communication. The researchers found that 69% of the participants reported observed deficiencies such as involuntary interjections and poor fluidity in Flemish Sign Language users. They also suggested how stressful events or unpleasant emotions could also lead to the increase in manual defluencies. Similarly, Montgomery and Fish suggested that stuttering-like defluencies are more common in sign language as opposed to spoken language among the deaf. In their study, they found that 12 students presented with stuttering-like behaviors in which 6 of them stutter when signing, 3 of them stutter when speaking and signing, and 3 stutter only when speaking. On the other hand, Silverman and Silverman's study showed that stutter-like behaviors in manual communication are more commonly associated with fingerspelling as with signing. Despite the differences in results across research on the effects of stuttering-like behaviors on sign language, all studies found that the most common stutter-like behaviors in deaf users of sign language are repetitions of signs and initial letter in fingerspelling, involuntary interjections, hesitations, prolongations, block, poor sign fluidity, unusual body movements, and increased muscular tension.
There hasn't been a lot of research done in stuttering in sign languages. Most of the papers that we found didn't actually use primary sources. Rather, a lot of researchers sent out surveys to SLPs, teachers, or assistants, asking them to report their observations. Obviously, this is a big issue because of how well or poorly observations were described, whether the interpreters were reporting stuttering or filler words, misinterpreting signs, and so on. Lastly, many of the papers don't mention or take into account concomitant disabilities that may affect sign fluency.
So why investigate developmental disorders in language acquisition for sign languages? For those looking into speech therapy and audiology, you'd be in a better position to provide more well-rounded recommendations, make referrals to sign-fluent SLPs, or execute more comprehensive learning strategies if you do choose to specialize with the deaf. This is also the case for educators, counselors, or ASL specialists. For those who want to get into research, this is a severely understudied discipline with tons of opportunity for discovery, especially in the development of standardized assessments and the efficacy of different teaching techniques. For our policymakers in school boards, workplaces, and in government, you can advocate for more funding into research, accessibility, and sensitivity training for all people with language disorders. You can highlight how communicative difficulty has long-term effects in socializing, being autonomous, and employment opportunity. As students of this class, we have the background knowledge to ally ourselves with the deaf community as the need presents itself, whether it's in classrooms or in coffee shops. What's most important on the whole is ensuring and protecting every person's human right to access education, language, and communication.